I always look at patients and say, are you happy with the expectation from the standard of care? Are you willing to consider a few extra drugs and supplements that will not only reduce the division rate of the cancer and make it more vulnerable to the standard of care, but also improve other general drivers of chronic disease at the same time?
You just heard from Dr. Charles Meakin, a radiation oncologist with over 35 years of experience and now the founder of Meakin Metabolic Care. He helps patients integrate repurposed medications and metabolic strategies with standard treatments. In this episode, he breaks down what repurposing actually is, where it can make the biggest difference, and why medical oversight is so important.
It is so lovely to have you here today to share your knowledge and experience of serving so many patients with off-labeled repurposed medication, also specializing in metabolic health.
Well, thank you, Peyton. It's lovely to be here. And I look at Heal Navigators as a wonderful tool for patients and, also a partner because we work together many times. But I'm a older physician and I've been working on oncology since I finished residency at 1989, which sounds like a long time ago, but the time has flown by. I'd say I was always, in healthcare, more sort of integrative in my mindset. I studied yoga and early into medical training, I always sought out courses in like nutrition and the mind-body connection. I did my residency out at Stanford, which had a lot of supportive things for integrative care in the area. So it was rich for opportunities. And then when I started practicing, I always tried to not forget the core lifestyle drivers that are important with health. I was a radiation oncologist, and when I retired from that in early 2019, I spent a lot of time going through the important lifestyle issues in cancer care, and that resonated with myself and patients, and I felt that I could still work within the standard of care and advocate for those issues. It was harder work because it takes more time, and it also involves a lot of conversations that, a lot of docs don't deviate into. When I retired from the busy work, I went back to school for a year. I knew I wanted to do something different, more directly in sort of integrative care. And I heard a lecture by Travis Christofferson at a meeting about using repurposed drugs that would address the metabolics of cancer. And this hit me front and center in a good way. I already had contemplated how we miss managing the energy generation of cancer cells and just target traditional therapies. We met, Travis and I, and he put me on to the company that had just started in England, Care Oncology Clinic. And from then on, I took on the responsibility of being their chief medical officer in the US. Travis presented a group of about 95 or 97 glioblastoma patients that used 4 simple low-cost drugs, and it more than doubled the median survival. This proved to me that it can really move the needle, because glioblastoma was certainly a stubborn cancer to work on. And so that opened the door for further exploration. Since Care Oncology, we moved on to my own project, Meakin Metabolic Care. And now we use a variety of drugs. It's much more known about the metabolic theory than it was back in 2019. The discussions are a bit easier, but it's been a fun road. I think we've helped a lot of people along the way. Some people say, Meakin, why don't you retire? And I'm like, well, it's more than just a job for me. It's kind of a mission.
I totally understand that. Finding your sole purpose, you don't really see it as a job, as you mentioned. For someone hearing this term for the first time of repurposed medication or off-labeled medication, what exactly is it?
In the US, the FDA-approved medications generally have like a primary purpose, and that's what they were tested for, and that's what they were granted insurance coverage and general acceptance status for. However, over time, these drugs, many of which have 4 to 6 pathways of cellular activity, have new effects identified. And sometimes they're side effects, but sometimes they're good effects. And those are what's called off-label use. And about a fourth to a third of prescriptions written in this country are for repurposed drugs for a non-traditional use. These are all FDA-approved, generally, drugs for human use. Now, I say generally because you mentioned fenbendazole, and that's one of the family of drugs called azoles, and that's a veterinary drug in the U.S. It's the human version of that is mebendazole, and that's what we generally prescribe because I'm a human doctor. And so mebendazole, doxycycline, metformin, and atorvastatin, or one of the statins. They're just very common drugs. In fact, I think atorvastatin was the second most common drug used in the U.S. for a period of years. Those drugs have their primary purpose, the statin for cholesterol, metformin for making you more sensitive to your own insulin and lowering your blood sugar and insulin levels. Doxycycline is an antibiotic, and then mebendazole is an antiparasitic medicine. But they also have now good evidence that they work on other pathways that impact cancer. There is a lot of what we call preclinical data. Preclinical data is the basket of data that would come from Petri dish studies, animal studies, phase 1 and 2, human studies, case reports, population reviews, and everything shy of a randomized clinical trial, the ones that lead to FDA approval. Some of them have a randomized trial with supportive evidence, like metformin was looked at with prostate cancer in a European study called the MANSMED trial by the European Society of Medical Oncology. And that was actually found to be beneficial with standard of care for metastatic and locally advanced prostate cancer. But many of these trials never test them in sort of a multi-drug use. And this cocktail effect is what we feel allows the most impact on multiple pathways, as well as allows us to use fairly low doses and pretty well tolerated, easy to measure, easy to track in patients, so not to disrupt their quality of life and their tolerance of the standard of care that may be going on as well.
Since you mentioned pathways, what that exactly means and how that ties into metabolic healing.
So we do have a lot of data that says people with insulin resistance, you can name the subtype of cancer, have a more rapid course and less survival. And yet we don't have standard of care doctors saying, why don't we help correct insulin resistance and do that through lifestyle and medications? Insulin is a anabolic hormone. It tells our cells, hey, we got food on board. Let's make new cells. Let's store some fat for the future. Let's turn off fat burning. So it's that promotion of mTOR, or mammalian growth signaling pathway, that high insulin levels triggers, and metformin mitigates. Statins, they have sort of a good name, bad name. When people speak to it, I say, well, we're not really trying to correct your cholesterol or modify your cholesterol. This works under that. It helps create a fasting environment in the body. It also downregulates that mTOR pathway, and it has other sub-pathway impacts. And so we try to use it as a cocktail effect in low doses with some pulsing of the drugs while monitoring liver function, kidney function, basic bone marrow function. Generally meaning greater than 80%, 85%. The doses we start with, we see that it's pretty well tolerated. I think there's growing acceptance of this, but it's still early.
Yeah, absolutely. Is there a way that people can use certain supplements instead of the repurposed medication if they feel uncomfortable? Say, for instance, like berberine for metformin.
Yeah, so that comes up a lot. And there's a lot of potential substitutions, and there isn't absolute knowledge on some of this, but we know how berberine generally works. It has more of a direct impact on blood sugar. Ultimately, you want to lower insulin levels, and it works in some ways similar to metformin, but it also works in an independent way. So I always encourage people to be on both. And since we can get 90 days of metformin for $8, it's not a dangerous, expensive bet to try it out. And most of the time, people are pleased with the low impact on their daily routines, their digestion. And so usually there's not much of a problem there. And we just coach people on stopping it at the proper time before CT scans and whatnot. This is exciting. We historically would make estimates from mouse studies and petri dish studies and human trials and say, yeah, we want to shift toward these drugs for this cancer. Now there's a program through a company out of London called Astron, and they've dissected very large public databases and looked at supplements and drugs, old drugs, new drugs, that sort of neutralize certain mutational over and under expressions. And so we can get a report at a modest cost. They can look at someone's genomic profile, which is a sort of a fingerprint of their tumor's mutational patterns, and put that into the Astron database with about a 2-week turnaround and get what supplements, what repurposed drugs will neutralize, or what we call synthetic lethal pairs, to these mutations. So this way we get a direct link to what's going on in the tumor and ways to neutralize it. Of course, there is a bit of integration where you take somebody who's already on some standard of care and how you layer on a recommendation for 15 new things in over 4 mutations, and how you layer those on, which drugs to choose, which ones are available in the US, which ones are most affordable, and so forth. So this is sort of new to the last 6 months. That has made my job easier in some ways, but sometimes harder because you got a lot more things to integrate. Plus, we're finding exotic things that we aren't in the typical list of repurposed drugs for cancer that are starting to pop out. So it's an exciting tool. But yes, a lot of times supplements and drugs can be interchanged.
I'm so glad you mentioned Astron because we actually had them on a podcast episode. So if you're listening, you can go back to our channel and find that. So why might a patient consider adding repurposed medication to their current cancer care plan?
So I always look at patients and say, are you happy with the expectation from the standard of care? If they got a T1A low-grade breast cancer that has a 99%, 98% probability of success, maybe they'll be more interested in strategies to prevent the future potential chronic health conditions. But if they have a stage 3 high-grade colorectal cancer that has about a coin flip prediction of success, my question to them is, are you willing to consider a few extra drugs and supplements that will not only reduce the division rate of the cancer and make it more vulnerable to the standard of care, but also improve other general drivers of chronic disease at the same time? The commitment is paying for some repurposed drugs and supplements, meeting with somebody like myself and our team 3 to 4 times a year, following labs they're probably already getting. So it's a trade-off. Some people really get it. They understand that, my goodness, a PET scan shows activity because it takes up fluorodeoxyglucose in a rapid way more than normal cells. And so we need to dampen down the availability of glucose and some of the drivers that activate glucose uptake. And so it makes sense to consider this. That's the most simple understanding. We see a lot of people with stage 4 disease and difficult cancers. Sometimes we see people too late, where they're sort of in the final throes and their systems are already starting to shut down. We do what we can. And if we see someone and we don't feel there's much we can do, we refund them or offer end-of-life support. But I think the challenge is to people to look at their situation and say, am I happy with the current outlook of managing this cancer? And if not, will I do this modest change to improve upon that outcome.
Are there specific situations where these repurposed medications can make the biggest difference for patients?
Well, most doctors follow a script and they, well, for your cancer, we follow this line here, and this is the treatment we start with. And then when that fails, or if that fails, we jump to this treatment and insurance pays for that. And then if that fails, or when that fails, we jump to this. And I always remind people that we're sort of selecting for resistant cells. We're doing step A, step B, step C. Had we done them all initially in a lower dose, maybe we would have snuffed out that workaround that the cancer cells do, maybe those circulating tumor cells that don't respond to the traditional targeted therapies, chemotherapy, radiation, and so forth. So if we use more of those up front, we sort of drive that cell population into the dirt quicker and more deeply, where normal immune function can clean it up. The multi-drug approach, even in like leukemias and lymphomas, so those were unsuccessfully treated until they used a multi-drug approach. And we see from some of the early trials, for glioblastoma, the CUSP-9 trial, which used 9 drugs, and that showed a doubling and more of outcomes. There's also the CLOVA study for simple low-cost drugs that, showed improvement in the glioblastoma. And then also in pediatric solid tumors, the COMBAT trial looked at 74 patients with a variety of additional drugs, which a dramatic improvement in the outcome compared to standard care. And then there's some planned trials that are in the works. Now, granted, sometimes these trials get published and they get noticed, and unless they got drug reps pounding on the door saying, try this drug, plus they're in the guidelines, they might not get as much attention. Most of these drugs that are in use are generic in status, so there's not a big revenue stream for drug companies to talk about it. Now, that being said, there's a group in England that have taken doxycycline, a simple old antibiotic, and they've modified it, and they call it doxymir, and it's in clinical trial. If they get verification in a randomized trial, they'll then have a new drug indication and be able to charge a lot of money for it, similar to mebendazole with a group at Johns Hopkins and a venture capital group. So when people say, oh, that's rubbish, well, it's not rubbish when you got venture capital groups putting a lot of money into this by slightly modifying the molecule, so then they kind of can claim ownership of it, no longer would be generic, and the cost will go way up.
Yeah, I know mebendazole, there's a lot of scientific evidence being used for glioblastoma specifically. There's some friends that their husband was diagnosed with glioblastoma, and that's one that I know I mentioned to them to try to get a script through their regular oncologist. Sometimes oncologists are willing to write that, but sometimes not. So
yeah, so like mebendazole, it was very cheap. It's an anti-parasite drug. And then a company did a small trial on pediatric pinworm, and then they reformulated it and called it Vermox. And a 100 milligram pill is like $300 in America. And so that's basically unaffordable for anybody, even with insurance coverage. So we like to use higher doses than that. In the US, you pretty much got to go the compounding route, or as some people do, get the fenbendazole, is flourished because of its popularity for human cancers as well. You want to make sure you get a legitimate source. Merck makes a veterinary version of it. The price is starting to get to the point where it's almost the same as human drugs.
Yeah.
We think maybe it has a little more challenge to the liver. I see more people, anecdotally that have high liver enzymes after starting their course of fenbendazole. So that's always a point of discussion when we see people like mebendazole, fenbendazole. And so we try to flush that out.
Since we're already speaking of fenbendazole, I wanted to ask, outside of being a doctor, right? Because you can't write a script for fenbendazole. Can you kind of touch on why you might use fenbendazole versus mebendazole in some instances? Because I do know it can be interchangeable in some cases.
Yeah, so And this is an ongoing gray area, I would say. I've asked Thomas Segfried, who does a lot of work with mice and these drugs, and these azoles all do a few things. One of the things they do is they lock up the microtubules, and this is similar to like the taxanes and other chemotherapy agents. And the microtubules are necessary when the DNA separates to make two daughter cells. It's kind of where it looks like two jellyfish pulling apart. And so that mimics some chemotherapy effects. And then secondly, it's a mild glutamine uptake competitive inhibitor. So it diminishes some of the uptake of glutamine, we're told. Dr. Segfried and his team, I asked him this about a year ago, he still can't distinguish any major variation in sensitivity in a mice model. Now, mice models are a good start. They're different from humans. So I'm a little bit agnostic. So if somebody is doing really well on fenbendazole and they have a good supply and they are responding when we meet, or they seem to be in a good state, I don't derail that. On the other hand, if they're starting anew, describe the dilemma, and then we decide if we want to use mebendazole or they get fenbendazole on their own. So most people start with mebendazole, the human form. We also think there's a little bit of dose variation. And then I've had patients who say, like you're thinking, Meakin, but I'm going to use both. And they, as long as their liver's doing well and their digestion is good and they're maintaining their body habitus and muscle, bone, and fat levels in a good way, we don't derail that. Well, I always try to have a day break where they don't use most of the supplements and repurposed drugs on Sunday. We start mebendazole 3 days a week, always with kind of a fatty snack because it absorbs better with that.
Thank you for touching on that. I know this is a very hot topic, but how can these medications be used without chemotherapy, or does it absolutely have to be combined?
So yeah, that comes up as well. In fact, yesterday I saw a breast cancer patient who we had seen before, and I spent a good bit of the time encouraging her to not avoid using a aromatase inhibitor in her breast cancer care. She had shut off standard of care, and I'm like, hey, this is the low-hanging fruit. Maybe try it on a staggered dosing. And so a lot of times we, having sat through 1,000+ tumor boards and being an oncology doctor, but also having a widespread of integrative background, and every integrative toy I am either certified in or played with or used and whatnot, I bring that to the table. And I try to anchor good questions to ask their local doctors in a non-threatening way. Like I did with a lady earlier this week, I encouraged her to strongly follow her instincts on reinitiating a therapy that was standard of care that had really threatened her from a physiologic way. Part of it was saying, hey, you're on metabolic therapy. You've been NED, no evidence of disease, for over 6 months from stage 3 ovarian cancer. Your marker is in the basement. Things look good. That maintenance therapy was dropping your hemoglobin to the point of danger. Let's not tease the line. So a lot of times I pose questions that kind of trigger, yeah, let's think about this. Most of the things we can do can be easily layered on with standard of care. And that's the beauty of, seeing a doctor and not just posting, doses on social media that people try to follow and maybe don't keep an eye on their blood tests and so forth. So we try to do the best we can with this integrative metabolic approach in a real world virtual medical care setting. And I think we're unique in that capacity. Plus, we're very reasonably cost compared to, I know, some of the newer people out there that have very high starting points.
Yeah, there's just a lot of benefit from you being on both sides.
Well, I saw a lady yesterday, great couple that was on the phone from New Jersey. She was a 35-year career nurse, mid to late 50s, and she decided, I'm not doing chemotherapy. I've seen too many people, get in trouble from that. And so they had already started the modified ketogenic diet. And we had a discussion, and we started her on repurposed drugs. I said, let's don't close the door on stuff. Let's keep an eye on this tumor marker. She had a really good tumor marker that would reflect her cancer patterns, CA-125. And if we're seeing a good drop in that, maybe we ride it for a while. On the other hand, if it sort of just hangs steady or goes up, we'll iterate up, but don't close the door on the role of chemotherapy for this, because it does work. And so we try to, once again, pose questions that would make sense. And I think by the end of that, they resonated with that thinking. She had been told we got to do chemotherapy, surgery, more chemotherapy, and then maintenance therapy. And she was trying to get her arms around this multi-year big bite. I said, no. You do it one step at a time. Maybe after surgery, we say we're done, depending on what the numbers look like. So I try to anchor questions that can help people navigate some of the landscape that is difficult without derailing things, without always mandating things, but helping them ask good questions.
I think key is that you're open-minded. It doesn't have to be, yes, you have to do chemotherapy absolutely to see me. You have to have a biopsy absolutely to see me. Yes, these could be beneficial. These can give more information. However, you're very open-minded and accepting to where a patient is in their journey. I mean, that is very reflective on who you are as a human as well, but also the core values of your practice. So
yeah, the core values, we know a lot of the teammates, and whenever there's an opportunity to kind of go overboard and help somebody who's got financial difficulties or needs more care, we try to step up. And that's refreshing, I think, to a lot of people who don't always get an open door in some of the practice patterns. So
I agree.
we try to do our best in that regard. In general, for a year, doctor and them paying out of pocket for the medicines, of which they can sometimes turn into a HSA plan or a flexible spending plan, might be $2,000 to $2,500, and that's like for a whole year. On the other hand, if they want to get the big battery of labs we do, so we can really dial in with our metabolic optimization protocol calculator and sort of make sure that things that are often looked at are in line. We find a lot of things under the hood that we need to know about. Plus, the labs and the medicine adds maybe $300 to $500 for that year. And then some people want a wing person, a nurse navigator experienced in oncology and integration, and that maybe $3,000 to $4,000 a year with the doctor, the labs, the ongoing nursing support for a year. So the cost is not unreasonable compared to what I say all the time. The copay on your new chemotherapy will be more than a year of our work, So.
Yeah, unfortunately. And I always just remind people that anything alternative generally is not covered by insurance. However, people are trying to treat themselves. That's a whole another side of things. I mean, I hear, why should I pay for your services? I'm on the XYZ platforms. So what are the risks that can come by self-prescribing a repurposed medication without medical oversight?
Yeah, so there's a lot of nuances. Yesterday, I saw a lady who got hepatitis at a young age and had CT evidence of fatty liver. And so we know that statins utilize a lot of the detoxification pathway of the liver, and mebendazole uses a little bit of it. So we started really low with her, and we added a liver cleansing supplement, Tukco, right off the bat. And so that happens all the time. And she might have jumped right in, and a month later went in to see her local doctor and had LFTs that were through the roof. Earlier this week, I saw a lovely man for prevention from Seattle. He was in his mid-70s. He had a hemoglobin A1C of about 10. His fasting insulin was over 20. Blood sugar of 185. He was type 2 diabetes, pretty severe. So we had to really not just offer lifestyle things. We know from many studies that insulin resistance is sort of a core driver of a lot of chronic diseases. So I tell my family this all the time: your health is your first wealth. Spend a little time and money, look under the hood, make sure that things are not a problem. and then you can sleep better at night. So there is benefits to a tincture of good healthcare along with some of your self-driven lifestyle changes and supplements.
And see it as investing into yourself,
Yep.
right? And, all these forums, everyone's body is so unique. And also, a doctor I interviewed earlier this week said, test, don't guess, right? So you got to see what's going on with you specifically. Just because a protocol says to take curcumin might not be the best if you haven't tested or if you're on certain medications.
Sure.
Even with the supplement, a lot of people think, fenbendazole, ivermectin, different supplements, that these are natural, that they don't come with consequences, that they don't come with
Yeah.
interactions.
So there's a lot of transition out there. I mean, ivermectin is in most states a prescription, and mebendazole is, and we do use pharmacies that have best practices, and every drug gets sort of consumer lab tested to verify potency and sort of the pharmaceutical grade, lack of attenuants, and so forth. So once again, your health is your first wealth, and we encourage people to not get too cavalier with things. The other thing I always mention to people is that a lot of medications started as supplements. So just because it's a pharmaceutical doesn't mean it's industrial or bad. Metformin is from the French lilac. It started as a supplement. Many drugs are. And as a pharmaceutical, generally we know that it has greater oversight in the preparation of it than some of the supplements out there. I use consumer lab testing paid service to kind of choose the supplements we generally offer them through full scripts, which makes it easy to communicate.
No, it's important you touched on that, because do not get your supplements from Walmart or Target.
Yeah, especially over-the-counter generics, like buying ibuprofen. I don't want to throw anybody under the bus, made by a big, drugstore chain. They apparently have the greatest attenuants or greatest possibilities of bad carriers. And so a lot of times we'll put people on Advil. It's one of the synthetic lethal pairs in the Astron studies a lot. And so I say, try to buy the brand Advil. We know that's cleanest. Or if you're going to buy baby aspirin, get Bayer, things like that. So we try to bring that quality to our care. And it's been fun. As I said, I'm 66, could probably retire. I do it because it's a personal mission to me. It's people thank us being our wonderful team, and we thank them because it gives us a reason to get up in the morning and, tackle life.
So, Chuck, if a patient's curious about repurposed medication, what is their first step?
So I always encourage them to look at our website. We have some good information there. Look at Heal Navigator website, healnavigator.com, or Meakin Metabolic Care.com. We spend time curating 2 newsletters that go out every month that collect interesting articles. We also have a blog on hot topics that come out every month. And then another easy thing to do is just set up a 15-minute call with one of our care managers. And that's easy to do through healnavigator.com. That way you can speak to one of the many people that are familiar with what we do and either set up just a physician only or physician and big battery of labs that we review, or the whole physician nurse oncology navigation laboratory combination. So try to have something for everyone.
And we will drop that link for the advisory call in the description below for those that are wanting to connect. Those are some calls that I do, as well as our other advisors. Since people will be taking a lot of information away from this call, they might want to pose the question to their doctor. Is there anything that they should ask or anything that they should know? Because I do understand that repurposed off-label medication can often be 2 different worlds. Sometimes doctors can kind of disalign people from exploring this path.
Yeah, so this is kind of brutal, but ask the doctor to state the success of their therapy and sign it. So kind of call them on the carpet. And then when you look at that number, and sometimes it's not too positive, say, well, doc, what would you do? Would you take a risk on these low-cost medicines that generally have favorable impacts on other long-term disease to sort of layer on with this under medical supervision? We promise not to challenge the liver beyond what the standard of care drugs will do, and we'll modify for that. I mean, I think you'll probably get an answer if they're being frank. Sometimes we get, as you said earlier, a straight no, but I always encourage patients to have a doctor they can have a conversation with, and they know their doctor has their back, and they're not just a detour to getting home that night. So make sure you find a doctor that you can have a conversation with, that they care about your outcome. And if they do, I don't think they'll throw this under the bus. I think they'll be open-minded to looking into it. And so we can always offer some of the data out there that is growing to support this.
No, I was about to say that I've seen you guys supply additional information to patients or even new lines of treatment that maybe their doctors weren't aware of to potentially open more doors for those patients as well.
I'll finish with the thought that we try to remind patients that there is a strong impact of how we think, the alignment of our mind and body and spirit, and that as you've been thrown into a scary place sometimes, to reset and try to untangle what is most important to them and what they're willing to fight for, and write that down and put it front and center in their daily routine. Because then, if you know why you're doing it with great clarity, some hard things become easy. There's great data to show that a positive mindset impacts longevity. And so this growth mindset, this opportunity versus detour mindset can be a game changer for people. And so we try to remind people there's opportunities in some of these challenges.
Yeah, definitely find your why and get into that state of surrendering. And I think that's why it's so important to build a team around you that can hold that space for you and carry you through this journey and partner with you.
So it's a pleasure to be on the podcast, and hopefully we can reach out to people and serve their needs.
Thank you, Chuck. I always enjoy being able to connect with you. And for those that are listening, if you'd like to learn more about Dr. Meakin's Cancer Metabolic Optimization Program, or if today's conversation about repurposed medication raised new questions or made you wonder whether they could be a good fit for your case, we'll drop the link below. Again, thank you for tuning in. And until next time, take care and be well.